Hello everyone, my name is Dr. Yesudian, a consultant dermatologist based in the UK. Today I thought I will talk about a fairly common condition, rosacea, but will focus on a specific variant called neurogenic rosacea that is probably under-recognized in clinical practice. It was described about 10 years ago, but not many dermatologists are aware of this condition. Rosacea is classically divided into four main groups. Telangiectatic rosacea consisting mainly of the blood vessels, papulopustular rosacea where we get red and pus spots, ocular rosacea that mainly affects the eyes, and pharmatis rosacea that causes thickening of the skin, particularly in the nose. Neurogenic rosacea was described first in 2011 and is characterized by dramatic facial redness with burning, stinging, and dysesthesia or abnormal sensations that is out of proportion to the flushing or inflammation. It seems to occur more commonly in women, and the mean age is about the late 30s, although it is commoner in older age groups too. The triggers are similar to those seen in normal rosacea, including heat, sunlight, hot showers, exercise, and stress. Cooling the skin with cold compress or sucking ice cubes, particularly under the tongue, can relieve some of the symptoms. It seems to have a connection with the nerves than the blood vessels, so it is called a neuropathic problem. Here is a typical example of a 35-year-old lady with facial redness who also experienced flushing with burning and stinging pain after exposure to hot showers and sunlight. There was no response to the classical treatments for rosacea, including topical metronidazole or oral antibiotics. Topical steroids also did not help. The condition improved when she sucked on ice chips. There are some associations that are worth noting. Some patients may have neurological or neuropsychiatric conditions, including essential tremor and depression. Rheumatological problems like Raynaud's can also coexist. Headaches seem to be more common in those with this condition. Although the pathogenesis of rosacea is not fully known, dysregulation of the immune system, imbalance of common skin microorganisms, and abnormal neurovascular signaling are considered to be implicated in the development of rosacea. Trigger factors of rosacea such as exposure to sunlight, heat, alcohol, spicy food, or exercise can activate peripheral sensory nerve endings, which suggests that neurogenic inflammation may be involved in the pathogenesis of rosacea. In an individual person, the relative importance of each one of these mechanisms may differ, therefore influencing both the symptoms and the optimal treatment strategy. The management is difficult and a poor response is typically seen with standard treatments used for rosacea. So the use of topical metronidazole, ivermectin, and steroids tends to be unhelpful. Oral antibiotics also does not confer much response or benefit. Just a couple of cautions about aggravating factors. It can be triggered by lasers or light-based treatments and cause a secondary photosensitivity, so it may be useful to do a small test patch first before considering laser treatment as a modality. In fact, in those with significant neurogenic symptoms, it may be best to avoid lasers. Some success has been seen with neuroleptic agents, especially pregabalin and gabapentin. Tricyclic antidepressants and pain-modifying antidepressants like duloxetine may also be helpful. In a small subset of those who have this condition, hydroxychloroquine has also been known to be useful. However, the number of publications on the management of this distinct entity is very limited, and so all treatments must be used with a degree of skepticism. The authors of the first publication on neurogenic rosacea therefore suggest that we treat rosacea depending on the type of symptoms that predominate. We need to use beta blockers and vascular lasers for the vascular changes, antibiotics and immune modulators for the inflammatory changes, and neuroleptics for the neuropathic symptoms. So in conclusion, neurogenic rosacea is probably under-recognized. It should be suspected in any patient with rosacea where the predominant symptom is pain and/or burning sensation, particularly when it is out of proportion to the flushing. We need to recognize this entity as its treatment is different from classical rosacea. I hope you found this information helpful. Thank you for listening and bye.